Hello, good morning, good afternoon, and good evening to all our speakers, shares, and wonderful audiences in different parts of the world. Welcome to ACNS Webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Toru Yoshiura. Dr. Yoshiura is the chief of the Department of Neurosurgery at the Kyoto Sasekai Hospital, Japan. He is also a veteran who served as a lieutenant commander in the Japan Maritime Self-Defense Force. He is a core member of the Under 40 Committee of Japan Society for Neuro-Oncology and the Japanese Board of Stroke. And we are extremely honored to have him today at our webinars, and today he'll be talking about endoscopic endonasal optic nerve decompression. The speaker for the second session of today is our honorable guest from Zurich, Switzerland, Dr. Victor Staartjes. He is a neurosurgery resident and researcher in the machine learning in neurosurgery. He is a group leader at the MICN laboratory of the Department of Neurosurgery, University Hospital Zurich. He was a past fellow at the University of Stockholm and Karolinska University. He is a noted author with several publications in various peer journals, and we are extremely honored to have him today with us. And today he'll be talking about surgery for chronic subdural hematoma with concurrent ligation of the middle meningeal artery. The chair for the first session of today is our honorable faculty from Canada, Professor Pierre-Olivier Champagne. Prof. Champagne is a professor in the Department of Neurosurgery at the Laval University, Quebec, Canada. He is a skull-based neurosurgeon who specialized in minimally invasive skull-based surgeries by the application of endoscope. He was a former fellow at the Pittsburgh University, USA, and he is in charge of Laval University Cadaveric Laboratory, where he organized the yearly Laval skull-based course. He is a renowned author, has published several articles in various peer journals, and we are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty from Singapore, Professor Vincent Ng. Professor Vincent is a consultant neurosurgeon at the Mount Elizabeth Hospital, Singapore. He was the previous head of Department of Neurosurgery at the NNI Singapore, and he is also the co-editor of the Endovascular Center and director of the Joint Neurovascular Service at the NNI. He is the current vice president of Clinical Neuroscience Society, immediate past chairman for the chapter of Neurosurgeons Academy of Medicine, Singapore. He is also a member of the CNS, ANS, and he is an expert in endoscopic skull-based surgery, and was also the host for the recently concluded IFNE annual congress. And we are extremely honored to have him today to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Professor Champagne.
Thanking you very much for having me this morning. So, as I already said, we'll be starting with the first session with Dr. Toru Yoshiura, who is going to talk to us about the endoscopic endonasal optic nerve decompression. So I will leave them to you, Dr. Yoshiura.
Thank you for your kind introduction. I'm grateful for this valuable opportunity to present. I'm Toru Yoshiura from National Cancer Center Hospital in Japan. Today, I'd like to talk about the usefulness of the transnasal endoscopic approach for optic nerve decompression. I was a lieutenant commander in Japan Self-Defense Forces and now a retired military officer. Now, I am training in awake surgery for gliomas at the National Cancer Center Hospital in Japan. This is my third presentation for the ACNS webinar. Please let me introduce my previous presentations. The first was on fiber dissection and fiber tracking using MRI. I teach how performing actual fiber matter dissection allows us to visualize fibers, which in turn leads to image-based and functional anatomy. The second presentation was on bypass anastomosis practice using a desktop microscope. I presented my own learning curve regarding anastomosis time during bypass practice, demonstrating that with approximately 200 stitches, the time per stitch can be reduced to 2 minutes. I also explained how to visualize an actual surgery and make the practice as close to it as possible. Please be sure to watch the videos by scanning the QR code. I've gone a bit, but let's get back to the topic of endoscope. Introduction. The main indication is traumatic optic neuropathy. Primary injury involves direct nerve damage, which cannot be improved, but secondary injury occurs from circulatory disturbance or edema, and decompression can be effective. It is also useful in compressive optic neuropathy caused by tumors or aneurysms. When considering the criteria for emergency surgery, the first step is to perform the swinging flashlight test to confirm the presence of relative afferent papillary defect (RAPD). The diagram shows a case of positive RAPD in the right eye. Our institutional criteria for considering urgent surgery are indicated when RAPD is positive and vision is progressively declining but light perception is preserved. Previously, we used a transcranial epidural approach, and then since 2022, we have adapted the transnasal endoscopic approach. Case 1 is a 20-year-old man with traumatic optic neuropathy after a bicycle accident. Preoperative visual acuity was 0.04. RAPD was positive, and the CT showed a fracture line in the optic canal. We decided to perform a left optic canal decompression. 3D dimensional CT images were so helpful in identifying the exact site for decompression. The decompression area is the bony optic canal itself and the preforaminal segment, which is located just beneath the falciform ligament. Preforaminal segment marks the optic nerve's entry point into the bony canal. In such a simple case, we generally use a unilateral approach via a single nostril on the affected side. We enter through the spinal sinus via standard septal approach, just like in pituitary surgery. After confirming the skull-base structures, at first a preforaminal segment, which is just the medial area of the bony optic canal, was opened by drilling. Here. Then, the opening of the optic canal was performed via ethmoidal trajectory. We completed decompression by opening the optic canal from the preforaminal segment to the orbital apex. Finally, the exposed optic nerve cyst was covered with an artificial drum material. On post-operative day 24. On post-operative day 24, the corrected visual acuity in the left eye slightly improved to 0.08, and the visual field defect had partially improved. Case 2 is a patient for whom the transnasal approach was considered especially valuable. A 29-year-old man with severe head trauma by a motorcycle accident. He had bilateral frontal lobe contusions and crushed fractures from the anterior skull base to the pituitary fossa and crevice. His bilateral RAPD were positive, and the visual acuity were bilaterally counting fingers. But 24 hours later, the left visual acuity deteriorated to right perception. MRI with fat-suppressed STIR imaging showed hyperintensity in the left optic nerve sheath, suggesting edema as a second injury. Then we decided to perform optic canal decompression combined with skull-base repair. 3D-dimensional CT MRI fusion image showed a fragment of the damaged bone may be compressing the left optic nerve here, but the adjacent IC wall revealed no regularity, so we confirmed there was no sign of ICA injury. Then we decided to use a transnasal approach alone. This approach was done through the bilateral nostril. When the sphenoid sinus was opened, a major CSF leak was seen. We prepared a nodoceptal mucosal flap and sphenoidal sinus mucosal flap were preserved with the pedicles. The pulsation of C3 segment of the IC was confirmed, marking the medial OCR. The CSF leak apparently originated from the frontal skull base and contused brain was seen. A bone fragment from the tuberculum cella was pressing the optic nerve sheath. It was carefully removed and the left optic canal was opened via ethmoidal trajectory to close the CSF leakage. An abdomen fascia into the bony defect covered and the anterior skull base with sphenoid sinus mucosa with pedicle. Furthermore, overlying abdominal fascia and finally placed the nasal septal flap. After the surgery, vision improved to 1.0 and the CSF leakage resolved. He returned to work 6 months after the surgery, but visual field defects from the primary injury remained. In the past 20 years, we performed 10 optic canal decompression since 2022. 4 patients were treated by endonasal approach with visual improvement in 3 of 4 cases. Discussion. The optic canal is a short bony canal, typically about 6 mm length, and the distance between the middle and lateral OCR can be a useful landmark for estimating its length. To plan the decompression properly, it is crucial to evaluate the extent of optic nerve involvement from the preforaminal segment beneath at the falciform ligament, optic canal, optic apex, or intra-orbit. From the viewpoint of decompression range, a craniotomy has been reported to allow wide range of about 2/3 of the canal's circumference, while the transnasal approach provides access to around only 1/3. However, by using extended endonasal techniques, decompression of up to more than 180 degrees is possible. But I think optic neuropathy benefits from decompression is not caused only on simple mechanism compression but also by secondary injury. So rather than focusing only on the circumferential extent of decompression, it is crucial to expose the entire optic pathway from the preforaminal segment to the orbit, orbit and to ensure adequate decompression at the necessary sites. The choice between an opening craniotomy and the transnasal approach depends on several factors, including the location of the injury, the presence of CSF leakage, and skull-base stability. In particular, as demonstrated in case 2, the transnasal approach is highly effective and less invasive for traumatic optic neuropathy associated with the central skull-base fractures complicated by CSF leakage. In summary, we performed 4 endonasal optic canal decompressions. This approach was especially effective for traumatic optic neuropathy with central skull-base fracture and CSF leakage. Preoperative CT MRI 3D fusion imaging is useful for surgical planning. Thank you. Thank you very much for your attention. If you have any questions, please contact me with QR code.
Thank you. Thank you very much for the very good presentation. It was very interesting. I maybe have 1 or 2 questions for you. First, about the how we evaluate this patient in the clinical setting, because with trauma patient, sometimes their Glasgow scale is not good. It's tough to evaluate the vision. What I would be curious to have your opinion about these cases that because sometimes it takes quite a force and a trauma to cause these fractures, usually happening in highly pneumatized sphenoid sinuses. Do you think my impression is that there's many cases that we miss that actually we're not able to evaluate correctly the patient for them to benefit with these surgeries?
Thank you for your question. Real head trauma injuries patients are usually low Glasgow coma scale, but these cases are relatively good Glasgow coma scale, so we can evaluate neurological functions, including visual acuity. And case 2 is referred to our hospital 10 days after injury.
All right.
So we can evaluate.
And my other question was about the use of, so when you're drilling over the optic canal, do you use irrigation? What kind of irrigation
Yes.
do you use?
What kind? So we usually use irrigation with endoscope. So
Is it continuous or is it transient?
transient.
Transient. Okay.
Yes.
Are you do you worry about the potential of thermal injury in these cases with transient irrigation?
Of course, we use for summer injury or clean the blood. Both reason.
Okay. And one last question in that second case you showed with the of course you had to use a nasoseptal flap to correct also the CSF leak that was there, but was there any worries about because these flap you have to put some pressure on them for them to hold in place, So was there any worries about the pressure you had to put on the flap to correct the CSF leak, but at the same time not to cause more injury to an exposed optic nerve or optic nerve canal?
We decompress all entire optic nerve from preforaminal segment to orbit apex. So we use nasal mucosal flap and abdominal flap pad or abdominal. We use any flap or bony abdominal fascia on the bony structure.
So you use a
Adhesive
multi-layer
material.
reconstruction with nasal septal flap and fat?
Adhesive material.
Like fibrin glue?
So, fibrin glue, yes.
Okay.
So we think these materials not compress the optic nerve.
Perfect. Thank you very much. That sounds good. So I think this was all for me for the question. Thank you very much again for this presentation.
Thank you very much, Prof. Champagne and Prof. Yoshiura, for this wonderful presentation. We can open the house for discussions. Any questions? My co-host Liu Bun Cheng.
Thanks, Raja. Thanks, Prof, for a nice lecture. I have two questions, Prof. One is, how do you assess the degree of compression? Is there any case that you observe there's a rupture but minimal compression? Maybe with negative RAPD, would you decide not to decompress? So what's your criteria for decompression? My second question is regarding the use of methylprednisolone for optic neuropathy. How long and what are the doses that would you prescribe for your patient? And how long would you think that the methylprednisolone may not be useful and you decided to stop the medication?
Thank you for asking me. For second question, methylprednisolone we use, of course, Japanese guideline for traumatic injury recommend 250 milligram methylprednisolone 4 times a day for about 3 days. But in second case, we use 1 gram methylprednisolone for 3 days because we thought secondary injury edema is affected the optic nerve neuropathy. So we usually use 250 methylprednisolone 4 times a day. And the first question
Regarding how much the optic canal narrowing would make you decide to do a decompression? Or do you base on the clinical or the degree of compression?
we usually decompress at least preforaminal segment. As it is possible, we decompress to the optic orbital apex. Here, the degree of compression as possible as we decompress under the optic canal bony structure.
Thank you very much, Professor.
Just one question I would like to ask is, do you use a lumbar drain in all these patients to drain CSF?
Only one patient, so I showed the case too. He was a severe CSF leakage.
Sometimes the CSF leak may happen after you remove that bone piece. So whether you would embark on a pre-operative lumbar drain itself, just as a precautionary measure?
As of course, we use lumbar drainage.
Okay. Thank you very much. There are 2 questions in the chat box. In traumatic optic nerve blindness but no compression, do you decompress? I don't think he would do that because it all depends on the degree of impingement. And second is, thank you for excellent presentation in patients with traumatic optic neuropathy associated with central skull base fracture. How do you determine the optimal timing for endoscopic decompression to maximize the chance of recovery? Timing, he is asking about the timing, like end of 1 week, 48 hours.
As soon as possible, but if the patient had no RAPD positive, so that RAPD is negative and right perception disappeared, this is not indication for optic nerve decompression.
Yeah, understood. Thank you. Thank you very much. So that with that, we come to the end of first session. And any concluding remarks, Prof. Champagne?
No, not from my side. I think thank you again very much for this kind of invitation. Unfortunately, I will since I'm abroad, I will have to leave after. I won't be able to stay for the rest of the session. But thank you very much for having me.
Thank you very much for taking up.
Thank you very much, Dr. Yoshiura.
Thank you to both the chair and speakers for the time and support for ACNS webinars. We can move on to the second session. I would hand this podium over to Dr. Victor to go ahead with his presentation.
Yes, can you hear me?
Yes, and see as well.
Thank you so much to the ACNS and to you, Professor Kuti, for inviting me. I'm going to be talking about a little study that we did on a very simple topic, much simpler topic than before, but I think still very relevant nowadays, that there's so much discussion about how we can better treat chronic subdural hematomas. No relevant conflicts of interest. And this is a study I will be talking about, recently published in Operative Neurosurgery. And I think, Professor Kuti, I think we got in contact because I posted just that we published this on LinkedIn, and then I think you saw that and we talked about it a little bit. So I'm very thankful that I get to present our results here in this nice audience. I first want to take a step back and say, of course, the major problem that we have surgically in chronic subdural hematoma, it's a very simple surgery, but it's the recurrence rate. So symptomatic recurrence and even reoperations in the literature, somewhere between 15 and 33% of symptomatic recurrence, and maybe, of course, about half of that maybe in redo surgery that is necessary. So that's the major problem that we have. Of course, I'm not going to go through the entire pathophysiology of chronic subdural hematomas, but I want to focus a little bit on the vascular part of the pathophysiology, which is this vascular vicious circle that incorporates the neovascularization of the membranes, which then in turn leads to more inflammation and rebleeding, which then again leads to this vicious cycle due to the very extensive arterial supply through the MMA, Middle Meningeal Artery, of the membranes. And here again, this vicious circle is shown. So if we start with the angiogenic factors that promote the formation of capillaries within the membranes, these capillaries then lead blood, which this blood, the hemoglobin, leads to inflammation and activation of the membranes, which leads to more membrane development, which then again, these more membranes, they continue to exudate more fluid and blood, which in turn, again, as this vicious circle, leads to more bleeding and more inflammation and more membrane development. So there's the circle that we try to interrupt when we evacuate the chronic subdural hematoma, of course. And the reason that they sometimes occur is due to this battle or this balance of continued plasma effusion and rebleeding from the membranes versus complete reabsorption. And to help in this battle, one important tool has, of course, been added to our arsenal. Recently, in the last couple of years, it had been studied quite well, which is, of course, endovascular MMA embolization. There have been several quite good studies done on this, and I don't have to go into detail on this, but just I made a small overview. You can see that most of them show, or at least all of them show a less symptomatic recurrence, and some of them less reoperations also with MMA embolization versus only evacuation or standard treatment. Not all of the studies show a significant difference though, but I think overall this has of course led to relatively widespread adoption of MMA embolization In some hospitals, for example, in our hospital, we use it primarily for high-risk recurrence patients, especially the ones that have already recurred. We don't use it for all patients, but there are hospitals, at least in Europe, that use MMA embolization for nearly all chronic subdural hematoma patients, even without recurrence yet. And some of the guidelines are also even recommending, of course, for high-risk patients to use embolization. I don't have to go, of course, through the details of normal surgical evacuation of chronic subdural hematoma, but I just wanted to show the standard and then what we try to improve on it. So in our center, we use 2 burr holes almost always, and the frontal burr hole we put at the stephanion, the crossing of the coronal suture and the superior temporal line, and the parietal one we put at the parietal tuber. And then we make our burr holes. We open the dura flush for quite a long time. And then we usually use a subgaleal drainage, not the subdural drainage, but the subgaleal subcutaneous drainage. And so that is approximately the standard, I think, all around the world with some variations. But the question is, now that the neuroradiologists, interventionalist colleagues are adding, trying to help these patients with embolization, is there something that we as neurosurgeons can do, an easy thing, to perhaps decrease the recurrence rate? And the idea that comes to mind, of course, is to try and simultaneously evacuate the hematoma and at the same time occluding the MMA surgically. And this is, of course, not a new idea. I'm sure that there are many surgeons who have done this as a standard for many years. But right now, it has become a little bit more popular topic in research. So one study I want to highlight is one of our Swiss colleagues from Bern, who showed a technique where they use also 2 burr holes to evacuate the hematoma and then make a third targeted burr hole at the pterion to basically disconnect the MMA at its bifurcation, just before its bifurcation. And this worked really well. And then also there's this very nice study from Germany, from the Charité, where they have looked at how to find basically the MMA bifurcation using a template that starts from the external auditory canal. As you can see here, you can see this template that goes in the auditory external canal, and then you line it up with the zygoma, and then a couple centimeters perpendicular to that here, this is the location where on average the MMA bifurcation should be, and then they validated this with neuronavigation on several craniotomies, and it was quite a good match usually, because there is not a huge anatomical variability in this MMA bifurcation. So what is it that we wanted to add to the literature? We made a very small contribution to the literature trying to answer 3 questions, namely, firstly, can we describe the craniometric anatomy of the MMA and especially its bifurcation on non-contrast CT? So how well is it visible? Is it visible in all patients on non-contrast CT? Because that is the imaging that we usually have for the patients with chronic subdurals. Second question, main question was, if you want to simultaneously evacuate and occlude the MMA, then optimally you would want that you could do it with 1 burr hole that achieves both goals. And so we want to know how many % of patients lend themselves to this technique with simultaneous occlusion through the same burr hole, and how many you have to make a second burr hole. And the third one was to make some, in the absence of navigation, if navigation is not available or doesn't need to be used, then we wanted to provide some craniometric measurements to still identify the MMA bifurcation. So we looked at a short, I think it's a 1-year consecutive series of 24 hematomas that were evacuated, and I can already give you the answers to the questions I said before. So first one, can we identify the MMA clearly and its bifurcation clearly on non-contrast CT? And yes, in 100% of the patients that we looked at, it was easily possible to identify exactly where the bifurcation is on using the groove of the MMA, of course. And then as a side note, of course, most of patients have a frontal MMA branch that is clearly dominant. The second question, which is maybe a bit more interesting, so how often is it possible to use just 1 burr hole to achieve both evacuation and occlusion, surgical occlusion of the MMA at its bifurcation. That should be possible in 75% of the hematomas. That is cases 75% where there is some good overlay of the hematoma and the bifurcation. Of those, though, it is important to mention that only 21% of all hematomas, it is the case that the bifurcation is at the point of the thickest hematoma, so the optimal point where you would usually want to place your burr hole. So in about half of the patients, it is possible to evacuate through the same burr hole, but it's a bit at the border of the hematoma. And here, just to illustrate that, on the left bottom, you see the osseous groups, obviously, and on the top right, you see the different situations you can have in terms of the anatomical variability and the variability of the hematoma in relation to the bifurcation. So in 75% of cases, it will be either A or B, so it's possible to do everything through one burr hole, theoretically, but only in 20%, 21%, the burr hole is like in situation A here, exactly where you would usually want to optimally place your burr hole, and in the rest of the cases it is more at the border. And then there's 25% of cases like panel C, where the bifurcation is just not overlapping, and you would need to make at least two burr holes to achieve both surgical occlusion of the MMA and evacuation. These are also then some of the craniometric measurements we made. Very simple. I think what we focus on is, first of all, a method where you measure from the Stephanion, because the Stephanion is a very constant and easily identifiable landmark. So we wanted to measure how much down and anterior from the perpendicular from the Stephanion you have to go to hit the MMA bifurcation. And then the other way is similar to the study from Berlin, to go orient yourself from the external auditory canal alongside the zygoma and then upwards. And then these are the results regarding that. So if you want to take home these measurements and use them, it's basically the easiest, probably I would say for me, from the Stephanion. If you take the Stephanion, you go 2.5 centimeters caudally downwards. That is this A line. And then 1 centimeter anteriorly, you will in most cases end up exactly at the bifurcation of the MMA. And then if you want to go from the external auditory canal, you have to move along the zygoma 3 centimeters anterior and then 5 centimeters cranially in a perpendicular fashion. You will also find the MMA bifurcation. Of course, if available, I would recommend to briefly using neuronavigation. I have myself used to do this electromagnetic neuronavigation, because it is quite cheap. You can mark it on the skin. You don't need to open sterile. You don't have to open any sterile single-use goods, and it takes maybe 2 or 3 minutes longer, and then you have more personalized, and you will for sure find that you can plan it a little bit better. So, I mean, I think it's obvious to us all now, also with this information, that it's absolutely possible to do this. The question is, what is the evidence in the literature, and could it really help reduce the recurrence rate? I just wanted to show some things I found in the literature. So this was a Chinese study where they showed a case report of basically very similar to what I showed. They measured using a 3D reconstruction. They measured where they wanted to place their burr hole, here parietal, and also at the same time occlude the MMA. But what they did different to what we propose and to do is it is a very distal occlusion. So I would recommend to occlude it if possible at the root of the MMA. Then this study actually did that. These were 9 patients with 11 hematomas, where they used in most cases, a single burr hole to achieve both to evacuate the hematoma and to coagulate and divide the MMA at its bifurcation. Interesting here also, which corresponds exactly to our study, 9 patients with 11 hematomas were operated, and of those, 2 patients had to have multiple burr holes because there was no overlap between the hematoma and the MMA bifurcation. So that's exactly the same ratio as we found in our study. So about 25% of patients, you would have to make an extra burr hole if you want to occlude surgically the MMA and at the same time evacuate the hematoma. This is also an interesting study where they used a 3D printed facial template to mark the MMA where they wanted to evacuate and occlude at the same point. So that's interesting. And then I even found a study where they did a mini craniotomy and then actually did a endovascular embolization by directly puncturing, catheterizing the MMA, which of course has an advantage, which we will talk about a little bit later, that it's possible then to also do a more extensive embolization of even the smaller branches, the membranous branches, which of course is not possible when you just occlude surgically the MMA. So there is very limited clinical evidence. There's no comparative clinical evidence like for, of course, embolization, which has very good evidence by now. So the question is, will this work? I cannot answer this question yet, but I can give my thoughts on potential advantages and disadvantages of this technique. So what I could see as potential advantages is that you can then offer in a single surgical session, either in local or general anesthesia, occlusion and evacuation, which also has, I guess, a economical benefit compared to 2 sessions. It's also like the embolization usually is not used for all patients in most centers. But this is something that could be used for all patients that are even at the first time without the recurrence being operated for their chronic subdural. You could basically sacrifice all of the middle meningeal arteries as a standard potentially. Then if you can do everything with just one burr hole under the temporalis muscle instead of at the Stephanum, you could have a slightly better cosmetic result, and you don't have to use a plate because it's under the muscle. And one important point is that with the embolization, there's a small risk for reflux into the ophthalmic artery of the embolization material if there are larger anastomosis with the ophthalmic artery, or some MMAs have an origin from the ophthalmic artery. And that, of course, is not a risk if you surgically occlude the MMA. Though there are important potential disadvantages. If you just occlude the MMA just before its bifurcation, then you are not achieving the same level of embolization and occlusion of the hematoma and its membranes, because it is very well known that the smaller branches or the membranes are often revascularized or collateralized immediately from the contralateral side, for example, or from other meningeal arteries. And in the same idea, also, of course, you can only do the ipsilateral MMA. If you do the endovascular route, you can often do bilateral embolization, because it's known that bilateral embolization reduces the risk for recurrence more slightly better than unilateral embolization. So yeah, it's a different kind of biological plausibility that you get with occlusion and embolization. But we don't have any clinical data on the recurrence rates yet. As I said, in 25%, you would have to make an extra burr hole. That's a slight disadvantage because there's no overlap of the hematoma and the MMA bifurcation. So you would have to make at least 2 or 3 burr holes. Then you have to go through the muscle, which usually you would maybe not, which is slightly bleeding and more pain for the patients, definitely. And then, of course, if you're not using neuronavigation, there's some anatomic variability, but of course, we hope that these craniometric measurements can help still identify, even without navigation, the MMA bifurcation quite accurately. We were very proud to receive an editorial on our publication by Professor Andrei Sirko from Ukraine. I just wanted to recap some of the points that he made in his editorial. Of course, he stresses that the clinical evidence is extremely limited, but warrants scrutiny right now because this is a popular topic right now. And he warns against stating, which we of course did not do, but it should definitely not be stated that there is an equivalence of the outcome with true endovascular embolization, because that's just not true. He also stresses the point that only in 75% of the patients you have this overlap of the MMA bifurcation point and the hematoma. So you have to do personalized planning, and sometimes you have to use 2 burr holes. He also stresses what I said, the less comprehensive devascularization. So in the end, as I said, you have a less good biological rationale than an endovascular, more extensive embolization. And he also highlights this potential benefit with the no risk for ophthalmic reflux. And he suggests very clearly that we have to move beyond these feasibility and anatomical studies to comparative clinical trials. So my last slide, my personal cautious recommendations based on the data from our study and the literature and our experience. It is easily technically feasible to both at the same time evacuate and occlude the MMA and evacuate the hematoma simultaneously. In about 75% of patients, it should be possible through 1 burr hole. If you want to do a parallel burr hole for extra evacuation, of course, then it's 2 burr holes. And in 25% of patients, you would have to place an extra burr hole, as we saw, for example, in the study from Bern that I showed at the beginning. It is important to keep in mind, though, the distinct disadvantages versus true embolization. Only unilateral occlusion can be achieved, and you don't have this extensive embolization of the smaller branches, and you can have definitely reperfusion or collateralization from the other side. And I would recommend, if possible, using electromagnetic neural navigation based on non-contrast CT, because we showed that it's easy to identify the bifurcation on non-contrast CT in all patients. And if that is not available, neural navigation, then you can use our measurements that we made. So if you measure again from the Stephanion, just to repeat, 2.5 centimeters down and 1 centimeter anterior should get you quite safely to the MMA bifurcation. And if you want to measure from the external auditory canal, you have to move along the zygoma 3 centimeters anterior, and from that point 5 centimeters cranially perpendicularly, and then you should also arrive at the MMA bifurcation point. So I hope that this was interesting. Thank you so much for the invitation, and I will be very glad to discuss with you.
Thank you, Victor, for the great talk. I just want to question, you mentioned that 75, in 25% you will need to put in another burr hole. So that means that do you usually use navigation, or in general for your cases it's really just the craniometric?
No, I mean, so I haven't done this at all for all the patients, but where I've done it, I have used navigation, this electromagnetic navigation, because it's so quick to set up. It takes 2-3 minutes, and it doesn't cost anything because you don't take the sterile parts, you just mark on the skin. But yeah, there are several studies that have used, for example, the nice study from Berlin that have used and validated these craniometric measurements. And yeah, I think they're a very nice way to try and achieve some devascularization at the same time. Yeah.
Which is a very neat technique that actually for a long time our residents was always asking, why don't we do the MMA embolization while we're doing the chronic subdurals? So, but what is your gut feel after doing a couple of cases? Do you think that the recurrence rate is much lower?
I would not say much lower. We didn't analyze it actually in a lot of detail because some of these were relatively recent cases. But yeah, I don't, as I mentioned, I would be very cautious in saying any benefits yet, because I think we have to do some like really comparative studies, and I searched the literature in quite a lot of detail. There's really no comparative data. So that is the next step. Of course, it's possible, but is it as good, or is it a benefit compared to the endovascular route?
Good question. I thought this was a wonderful method. I think the ability to remove hematomas and coagulate the MMA is truly excellent in terms of reducing the recurrence rate. However, it seems that this method can only coagulate the anterior branch of the MMA. So what are your thoughts regarding the posterior branch of MMA?
No, I mean, yeah. So there you can do a more distal occlusion, but what we try with this method is to occlude it before its bifurcation. So to occlude both the anterior, the frontal and the parietal branch at the same time. So you have to make a lower burr hole through the temporal muscle. That is the goal of this technique. Yeah. So yeah, that is the answer to your question. And even if you do that, as I mentioned, unfortunately, you do not eliminate any of the strong collaterals that we know exist. We know even from contralateral that usually there are feeders. So yeah, the question really is, as Professor Vincent said, does it really help, or we don't know it. But I want to do a randomized study, so maybe I can collaborate with some of you, and we can do it. Yeah.
Well, thank you very much. One thing I would like to point out is, like, in your center you do 2 burr holes, right?
Yeah.
Yeah, but is there any major difference between a single burr hole and 2 burr holes? That is first question. And with regard to recurrence, if you see the literature, the definition of recurrence is quite wide, right? If you search the literature from 20 years before and now, the word recurrence is the most abused word in the literature for chronic subdural hematoma. So when there is no uniformity with regard to the definition of recurrence, the way we evaluate it, it gives a wrong message to others. That is why all these things come up. Maybe this is another gimmick for the industry to try new methods. I don't know. What is your take?
Yeah, exactly. I agree with that assessment. So your first question was about one or 2 burr holes.
Yes.
So we use 2 burr holes because that's the way we have done it always. I think in literature, if you analyze it, there's no difference between using 1 burr hole or 2 burr holes. But we like to see this clear communication through the membranes at the end of the surgery. But I think if you look at the literature strictly, there's no real difference, but there's no very good studies on this. And then your second question was regarding the heterogeneity in recurrence rates and definition of recurrence. Of course, this is, you see that a lot of the studies that on embolization that I showed were funded, of course, by the industry. And not all of them were positive. And of course, recurrence is something that is the indication to re-evacuate a recurrent hematoma is to some part subjective, according to the surgeon, of course. So we have to work, I guess, on a better definition of recurrence. And on the other hand, I think that it's interesting that now we are in the literature exploring so many other sources of this heterogeneity. Why do some centers have more or less recurrence? And for example, one thing that just springs to my mind is that there was this study recently using warm saline and cool saline, and they found that the warm saline had a lower recurrence rate, for example. So I think there's so many small technical differences that can make a small difference, and I hope that then this occlusion can also make a small difference, perhaps.
Maybe what you said. But I would like to tell you my experience, because I work in one of the largest volume centers in the world. We perform around 30 to 40 chronic subdurals per month. Okay, and we have done only single burr hole craniostomy so far. The largest reported series of CSDH is from my place, GMC Trivandrum. There are 2,300 cases of chronic subdural hematomas evaluated by Professor M. Sambashivan, who was a former honorary president of the WFNS. So his theory was to put a single burr hole at the site of the temporalis muscle, okay, and leave the dura open, because what he thought and his philosophy was this: the temporalis muscle is an excellent absorptive material. So whatever, if you just keep the dura open and drain some chronic subdural, the rest of the hematoma would be picked up by this temporalis muscles. So when he retired, maybe the others did not carry out this message, and we continued to do so. But now our theory is like to put a burr hole at the site, at the largest site of the thickness of the hematoma, or the most dependent portion and still we use the single burr hole only, and our recurrence rates are very low. In the first case, the series I mentioned from Professor Sambashivan's article published in 1997, his series was the recurrence was 4% only, around 2,300 hematomas that he operated. So I don't know what do you have to say, Prof. Vincent?
Raja, so I thought your comment was quite interesting about having the burr hole through the temporals as an absorption. Because our classical teaching, and I think Victor mentioned it just now, is to avoid the muscle because the risk of, especially if you leave the dura open, that the muscle is a bit hemorrhagic and it may bleed inside. So it's wonderful to hear that actually that is a myth that we have been telling our residents for a long time, that actually is the other way. So that's interesting observation.
Right, thank you very much. So I think there are few comments in the box if you'd like to address that. Vincent, he says, in your experience, which subgroup of patients benefits the most from simultaneous MMA occlusion at the index surgery? Do you select patients based mainly on recurrent risk, hematoma characteristics, anticoagulation status, or brain re-expansion potential?
This is something that I cannot answer yet. But my suggestion, as I said, is why not do it for all? I would apply it to all the evacuations. Yeah, because I think it is at least in 75% of the patients where there's a good overlap of the hematoma and the bifurcation, so you can get both anterior and posterior frontal and parietal branches. There's almost no disadvantage compared to just evacuating, I would guess.
Right, thank you. My co-host Liu Bun Seng, is he still here? Liu, would you like to ask anything?
Yeah, yes. I just wonder, Prof, because we used to do a Tirana burr hole, and maybe almost 99% we will see MMA. The issue is your skin incision. You can't do a skin incision on Tirana point. So how best, because that's the most proximal point, and accuracy is very there. You doesn't need to have any measurement. So will you consider looking at Tirana burr hole point, and how do you decide to do your skin incision, because you want to avoid a fashion of Prof?
Yeah, no. So I mean, there is a very close relationship of the terion and the MMA bifurcation, and our suggestion is to use either navigation to plan the skin incision or to use these craniometric points that I described, and they should get you near to the terion. Then you have made your skin incision and you can dissect a little bit to the sides and you can find the terion and you can make your burr hole exactly there. That is like my suggested technique, I would say.
I definitely will
Like you
support
said.
I will definitely support your effort, because it's much cheaper than embolization, and I think maybe it's much safer too. Thank you.
Yeah. No, in my opinion, we have to take this back to neurosurgery, away from neuroradiology.
Right, thank you very much. So with that, we'll come to the end of this session. Prof. Vincent, any closing remarks from you?
No, thank you very much for that. Sorry for coming in late. I'm dealing with an emergency at the moment. Just thank you.
Okay, thank you very much. So with that, we come to the end of today's webinar. I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Toru Yoshiura and Dr. Victor Staartjes, as well as the chairs, Prof. Olivia Champagne and Prof. Vincent NG, for the time and support for the ACNS webinars. Very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and also special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.